attendees to the webinar this morning. Just wait another minute or so. We're at 8:33 a.m. Eastern Time, New York time. We see that attendees continue to register and join, and so we'll begin in approximately minutes. Thank you for joining. Please note that we are recording the session, and it will be made available in case you are desire to see it afterwards or with colleagues. If you have questions or need technical help, please send an email on the email that you see on your screen. My name is Jerome. Or you can type them inside the chat window. So we're going to begin. Thank you for joining us. My name is Jerome Gallia, Deputy Director at Sociomedical in Lima, Peru, and fellow at the University of Harvard School of Medicine. And I'd like to welcome you all here today for the first in a new webinar series examining TB and mental disorders. Today's webinar is TB disorders, challenges and opportunities. Thank you for joining us. I'd like to draw your attention to a few housekeeping items before we begin. It seems everybody has muted their phones. That's great. Thank you. If you have questions or technical difficulties, do realize, and we apologize if we don't have call-in numbers today. This is strictly by internet. We do understand that may cause some technical problems. We provide a recording to all registrants after today's session. If you have questions, you can send them to me in WebEx. Or you can email them to me on the email address that was actually on your screen, but I also sent all of the confirmation emails, so you should have my email address, _Gallia, ms.edu. I also wanted to let you know that we have a number of future opportunities coming up, but Dr. Sweetland can tell you more about those. And to craft future webinars, we'll also be sending a brief survey following. Without further ado, I'd like to present today's speaker, Dr. Annika Sweetland. Dr. is Assistant Professor in the Department of Psychiatry at Columbia Mailman School of Public Health, and has been deeply involved in the area of mental health and tuberculosis since 1998, at least, working first in Peru in the public health site here called Sociomedical, as a volunteer and as a scientist, and many of you may know groundbreaking work with other colleagues here in Peru doing the mental health needs of patients with multi-drug resistant TB. She's also the co-chair of the TB Mental Health Work Group at the Union, where I was lucky enough to meet her a few years ago and become involved in this important issue. I think in the interest of time, I'll leave it at that and pass the microphone to Dr. Sweetland. Thank you.
Thank you. Can you hear me?
Loud and clear.
Okay, great. So welcome, everyone. Thank you so much for joining us for this webinar. Jerome mentioned this is the first of what we hope to be many such webinars on more and more specialized themes. This particular session is going to be an overview of the issues related to TB and mental disorders, and then look forward to hearing more from you all what you want to learn more about and plan for future sessions. And as Jerome mentioned, this is in case bad or if you miss anything or want to go back, this is recorded. This is going to be recorded. It will be stored on the Union website under the trip section. As soon as we have that we get posted, then we'll send out an email to all of the registrants so that you can have access to it. Let's give a little bit of background. The TB and Mental Health Working Group was established in 2015. Background: the mission of the group is to link frontline TB providers with researchers so that we can create an evidence base for best practices and disseminate them to global national TB programs. In meeting in Liverpool at the annual meeting in October, we in the working group met. We talked about a lot of things, but one of the main that came up and desire was that people were really asking for more information and more training about these topics, and so this webinar is actually a direct response to that back from the meeting in October. And I want to give a very special thanks to Jerome for setting this up and for really doing the live share of getting it going. And we hope to do several more over the next year. And some of you hopefully will continue in the group, and we'll see you at next year's working group meeting in Guadalajara. So I'm just going to give an overview of what I'll be talking about today. This was intended to be a broad overview of the intersection of TB and mental disorders, and we follow up with more specific topics. My first topic today will be to discuss how mental disorders increase the risk for tuberculosis. Then TB increases risk for mental disorders. What are the associated with comorbid TB and mental disorders? When you bring poverty into the situation and how all of those three things interact. We're going to treatment and what we know and what we don't know. Mental health treatment intervention. And fits into the NTB strategy. With how disorders increase the risk for TB. Well, there's two studies so far at this topic. One was a matched case control study conducted in Brazil among 1,400 people in a primary care setting, in which people with common mental disorders had a 1.34 times greater risk for TB. Another study that's more recent that's currently pending publication in this groundbreaking piece. It involves a population-based cohort of 64,000 people in Korea, followed over a 10-year period. And they found that individuals with depression at the beginning of that period had 2.63 times greater risk for TB after 10 years than those who did not have depression at baseline. and found that the risk was proportional to the severity of depression. This is really very strongly suggestive of this close link. Depression is known to be associated with immunosuppression. We can see these patterns or TB, where depression increases risk for other illnesses, diabetes, and cardiovascular diseases. And so this apparently appears to be the case with TB, and we need to do more research in this area. Starting from the very highest level, the world population covers 7 billion people, and 1/3 of them is infected with TB. Now, all 1 billion of them are going to get sick. In fact, only 5 to 10% of individuals who are infected with TB will actually develop active disease. But that comes to about 10 million new cases per year. It's still the leading cause of infectious cause of death worldwide and the leading cause of death for people with HIV, and comprises a massive public health crisis. Though relatively controlled in a lot of high-income countries, multi-drug resistance is leading to a resurgence even in high-income countries and furthering the challenges in low-income settings. So, factor that determines whether the body has an appropriate immune response and keep the latent infection isolated in the lungs versus the active disseminated TB. And there's different mechanisms through which immunity can occur. One will recognize risk factors for TB is poverty, and the ways through which this happens has to do with the nutrition associated with poverty, which can lead to immunosuppression. Poverty is associated with chronic stress, which can compromise the immune system. Chronic stress is a risk factor for mental disorders, which can cause immune function, in particular depression. Mental disorders can impact on diet and nutrition, which can increase the immunosuppression by that pathway, or also nutrition can lead to contribute to psychiatric symptoms. So this works, and doesn't even take into account other comorbid conditions, which also contribute both to mental disorders and immunosuppression, as well as social stigma. And that will be a topic for another webinar. So now talk about the other direction. How does TB increase risk for mental disorders? Well, there's factors that make people with TB have greater risk for mental disorders. First of all, TB tends to affect people who are already socially vulnerable, people with severe mental illness, homelessness, incarceration, co-infection with HIV, substance abuse, already living in poverty. And so being ill with TB exacerbates all of these underlying vulnerabilities. Reasons why the inflammatory response to TB, which is a protective response, will trigger depression in people without a psychiatric history. This has been seen with several other medical disorders. And the TB contributes to malabsorption of nutrients, which also may contribute to mental disorders. Great psychosocial stress associated with TB, particularly around stigma and discrimination, with the social isolation, also disability, inability to work, and ability to take care of one's children, disruption in plans of studying, for example, additional financial burden, and sometimes catastrophic costs associated with the TB treatment, even treatment is free, when not everything is covered, there can be a very good impact on families and contribute to mental disorders or increased risk for them. And for side effects associated with the treatment for TB, which can produce psychiatric. So, for example, cyclosporine is the medication most recognized to have psychiatric side effects. I'm going to talk about that a little bit later, but during systematic analysis recently, that cyclosporine produces psychiatric side effects in about 5.1%. All previous studies had reported up to 50%. So that's the most challenging medication with regards to psychiatric effects. However, there's other case studies and more lesions of psychiatric side effects associated with other medications such as ethambutol, acetylnitride, isoniazid, rifampin. So I'll talk about that a little bit later. There's a lot of stress associated with physical, just having physical side effects. This is particularly true for multi-drug resistant TB, where the treatment is very long, a lot of the drugs are very toxic, and having lots of side effects for a long period of time can be very distressing. In fact, there are other types of side effects, such as from clofazimine, which results in hyperpigmentation or a darkening of skin color. And that, in particular, in Peru, where I started my work, and I'll be talking about this a little later, that's very distressing for patients who are taking that medication because it made their skin sort of an orangish hue, and it was a very unnatural sort of color. It made it very difficult for these patients to hide their disease, and so encountered a lot more stigma and discrimination. What has to incorporate poverty into this picture? We know that poverty is a risk factor for mental disorders, and vice versa. We know that mental disorders are a risk factor for TB, and vice versa. And we know TB and poverty are mute factors. So what we really have here is a syndemic, as the conditions of two more conditions that act synergistically to magnify the burden of disease. Systematic review by the World Health Organization, they found that programs that include educational, psychological, and/or material support were associated with better TB outcomes. This can now be considered a best practice. The preliminary results were presented at a conference last month, and the publication of these findings is forthcoming. So when I say mental disorders, what do I mean by that? How do we differentiate a cluster of symptoms from an actual psychiatric condition or mental disorder? Well, that has to do with severity. These are extremely crippling and disabling. The degree of disability, it must arise where the symptoms interfere with a person's ability to work or interpersonal relationships. It has to, in order to be considered a disorder, the symptoms have to be significantly disabling and impairing. Disorders have a duration, a time window that's a requirement as part of the diagnosis. For example, for depression, a person has severely and disabling depressive symptoms every day, all day, for at least 2 weeks. And when a person has comorbid TB and a mental disorder, the sum is, or impact is that people with mental disorders are less likely to seek treatment right away, which means by the time they come to treatment, they tend to be a lot sicker, which affects their prognosis. Less likely to take all of their medications, to finish treatment, more to be lost to follow-up And as a result, they have greater risk for developing drug-resistant TB, death, and treatment failure, as well as infecting more because they have the risk of being contagious or infectious in the community for longer periods of time, thus put us to particular household members and immediate family members that might be exposed during those delays, sometimes drug-resistant strains. Mental disorders among individuals with TB. Well, we did 3 systematic reviews. The first one looked at only depression and found a weighted mean prevalence of 48.9%. Another study that looked at depression and anxiety found rates of 46 to 72%. And finally, a study found that any mental disorder rates were up to 70%. And a slight caveat here, which is that almost all studies to date have used brief screening instruments for mental disorders, which is not the same as a diagnostic assessment. So talk a little bit about short screening schools a little bit later, but things like the PHQ-9 for depression, it's a 9-item scale that is fairly good at detecting potential cases of depression. It's not diagnostic, though. It's intended as a screening tool to identify and flag people with potential disorders so they can be followed up. And so, the vast majority of studies that exist to date are only relying on those screening instruments, which is likely an overestimate of actual prevalence. And I just want to mention that both of these studies by Potch and Doherty are very good, very comprehensive reviews and summaries of the existing literature particularly about psychiatric side effects associated with treatment. But they are very, very good resource I would recommend. So now let's talk about alcohol and substance abuse. A systematic review found that people who with heavy alcohol use have about 3 times greater risk for TB incidence and reinfection. Estimate that as much as 10% of TB cases globally can be attributed to heavy alcohol use. It's also a significant challenge in terms of pose a challenge for adherence as well. When we talk about drug abuse, who addicted to drugs have a higher rate of latency as well as incidence, and more likely to delay seeking treatment and not take all their medications or not adhere fully to the treatment. About treatment. Can mental disorders improve TB outcomes? Well, there are relatively studies that have rigorously evaluated the impact of mental health treatment on TB outcomes. These studies I'm going to describe right now are the beginning of a limited evidence base that we hope to build over the next few years. There's also a study protocol that was published recently in BMJ Open, which we hope the findings of that study will be very illuminating. Let me go through each of these studies. Tola et al. Psychological and education interventions to improve TB outcomes, improve TB adherence in Ethiopia based on a health belief model, cluster randomized control. The sample included about 700 people. The intervention was psychological counseling, adherence education. Specific. It was psychological counseling based on the health belief model, and the outcome of interest was adherence. The group, the numbers that began at 19.4%, at the end point reduced nearly by half, by 9.6%. 9.5 to 9.5%, whereas in the control group that did not receive this intervention, the adherence actually increased over time from 19.4% to 25.4%. Study looked at alcohol treatment in Russia. This was also Partners in Health, effectiveness of alcohol treatment interventions integrated into routine care in Tomsk, Russia. This was a randomized controlled trial of approximately 200 individuals. The interventions included oral naltrexone and or brief therapy, and the expected outcome was to improve TB outcomes. TB patients with severe alcohol use disorders who were not seeking alcohol treatment and it did not respond to naltrexone or behavioral counseling integrated into TB care. How patients with past attempts to quit drinking did have modest effects. So this is an area that we still really need to study and learn about to understand how to treat comorbid alcohol use with TB patients. Now, this is interesting. Psychotherapy improves compliance with TB treatment. It's a single-blind controlled trial, about 200 people. The intervention was motivational interviewing, but interestingly, the sample to have baseline depression and anxiety. It was this motivational interviewing, which is an evidence-based practice often used for the treatment of substance abuse disorders, was used on everyone. So half the sample received this motivational interviewing type intervention around adherence, and the other half did not. The findings are staggering. The detention rate was 83% in the intervention group that received the motivational interviewing versus 48%. The default rate was a third of what was in the other group, from 17% versus 53%, and the cure rate was significantly higher, 72% versus 40%. The main observations that they had here, qualitative observation, is there was really a very low awareness of TB and even about infectiousness. I think a small proportion of patients actually knew that it was an infectious disease, and so this low awareness rate, likely this intervention really addressed both awareness and motivation when it comes to treatment adherence with significant effects. For psychosocial support groups for patients with multi-drug resistant TB, 5 years of experience. This is a psychosocial support group intervention I helped to start back in Peru back in 1999. Although it's a very old program and an old study, it's still remarkably relevant, particularly in settings where they're just beginning to address multi-drug resistant TB. And so these data came from a period of 1999 to 2004 in Lima, Peru, with Socios and Salud. The components of the intervention. The component was group therapy. This was initially weekly, and then after that became bi-weekly. And were of all types. It was all genders, ages. It was not specified on any sort of category besides the fact that the person was in significant stress or socially vulnerable, and such patients would be invited to the group. We had celebrations, symbolic celebrations once a month, and it was seemingly trivial. This was a very important piece of a small but important piece of the intervention, because what happened is this was one of the first treatment programs for multi-drug resistant TB in low-income setting, and it's been available before. So a lot of patients had failed multiple treatments, had been told they were going to die, really didn't expect to live to another birthday. And so birthdays were really emotive occasions and very significant recognition. So once a month, we would celebrate birthdays as well as patients graduating from treatment. The intervention was an open format, meaning that patients were integrated as needed, and then cured patients would drop out, and so the mixture of patients over time was constantly evolving. And family sessions, we did these about twice per year, and during these sessions, we invited interpersonal issues and conflicts were one of the main stress discussed in the focus groups and the support groups. We invited family members so that the family of patient A could learn from patient B. So we would split people up into groups where a member of patient A would be the T and could learn about the illness, not from their own family member, but from another patient in treatment, which is a very interesting and useful exercise we did twice per year. And then the final component was recreation. One year, we took the patients outside of the city, usually to a place in the country where they could play soccer and dance and have picnic. And these events were not only important to build the social network and the relationships between patients and this who had previously been extremely socially isolated, but also give patients what a lot of them referred to as like a mini vacation from treatment, because this was a tier treatment with excruciating side effects. But it gives, a lot of patients mentioned that it gave them hope in this idea of life, the normality of life after treatment and what it might look like. Sample includes 285 patients that participated in, there were 8 groups, 6 in metropolitan Lima and 2 in provinces outside of Lima. And 285 patients participated at least once. They were mixed, male and female. They're relatively low, a young group. The median age was 27, and the range was from 11 to 67. It was interesting with the big age mix in the group, because that often had to do some dynamic work wherein if a young person, a teenager, is coming in and expressing problems with their parents and difficulties with strictness and whatever, then we call on another patient who's a parent and have them give an opinion about what's going on. And so it was actually very, very rich. As attraction, it ended up being strength to have the diversity with the group, and the only common factor being the illness. About 40% had completed high school. It attended an average of 6 sessions, but as I mentioned, it was ongoing enrollment. So some did, others. And this is a very sick population. They were resistant to an average of 6 drugs, ranging from 1 to 13, had failed an average of 3 previous treatments with a range of 0 to 9, and had a median illness of 4.5 years. So these are very sick patients who've been sick for a very long time without access to treatment, and they're extremely socially isolated and socially vulnerable. With access to treatment prior to this intervention program, many families, many household clusters cases, and so more than half of the patients had a family, at least one family member with TB, and the range was 1 to 8 family members. And in that group, a quarter of them had at least 1 death due to TB, range of 1 to 4 family members. There wasn't a randomized controlled trial evaluating this intervention, and this is the sample. These are patients selected for social vulnerability and therefore not representative of the entire population. And as of March 2004, among 95 patients who completed treatment, 87.7% of these highly vulnerable patients had been cured. There were 3 relapses, 9 deaths, and only 10 patients defaulted from treatment during this period. Some quotes from the words of patients. One of the very important elements of the groups was also that we concerted effort to invite cured patients to sessions, at least 1 or 2 every session when possible. They were a huge source of inspiration to patients that were currently undergoing treatment, but also of what life could be like afterwards. So this is a quote from a cured patient who says, "Thanks to the therapy group, a group of people to whom I could say, I have this disease. I'm no longer locked up in my room, trapped between 4 walls. Sometimes I talk to the walls. I would ask God, why do you push me so? I realized that it wasn't a punishment because I met a group of real friends, ones that I truly consider friends, and tell them what I'm feeling, and I'm cured." And this was from a current patient, one who was taking clofazimine, which darkened her skin color, and she talked about the stigma discrimination related to that. To be a liar. When people ask why my skin is so dark, say I've gone to the beach or into the mountains. I mean, what can I do? I come up with whatever lie I can besides the truth, nothing but the truth. Because if they found out the truth, they would discriminate against me. Who wants to be marginalized? One has to lie. A very common theme in these meetings were suicidal thoughts. Many of the patients had considered suicide prior to or treatment. And this current patient, the patients who'd been in the group for longer, tended to set the tone for new patients who were just joining. In this case, a current patient said, "Oh yeah, all of us go through that. That's normal. The beginning treatment is so hard, but it gets easier. I thought about killing myself many times. The side effects were so bad. I was so depressed. Treatment seemed like an eternity. But little things got better. We'd be strong. We can't give up. The most important thing to know is that you're not alone. We're all in this together." The groups was that patients give concrete advice to others about how to tolerate side effects. So a current patient said, "I used to throw up every day. If I would hear the health workers knock on the door, I would begin to feel nauseous. I would take the medicines and throw up immediately. The worst that then I would have to take them again and again until I could get them to stay down. I found that when I would take them on an empty stomach, it was worse. Now I take them with fruit or yogurt, and it helps. It takes the taste out of my mouth, and I'm able to resist. Now I throw up. I'm able to keep them down, but always on a full stomach." Enough physical limitations and the ability to perform tasks that they were able to do prior to treatment. And this patient who says, "I was healthy. I used to be able to make 200 or 300 brooms a day. When I was in treatment, I only managed to make 3 or 4 a day. I used to get really tired. Now that I'm cured, I can make more and more. First I made 20, then 30. Now I make 100. Little by little return to normal. It's still as much as before, but I'm improving." The main in implementing this intervention were the common ones that one would expect: finding a private meeting space to hold the sessions, transportation, and possible and necessary, we tried to provide bus fare and or even pick patients so that they can come to the sessions. Some express the concern that listening to other people's problems makes me feel worse, and so we had to do a bit more stronger encouragement of such patients to come. But the main challenge was finding mental health providers willing to work with MDR-TB patients. It's a really tricky issue because, on the one hand, Peru is a middle-income country, so plenty of psychiatrists. So it also means that there is a lot of professional territorialism, and it was politically impossible at that time to think of having an institution that was run by anyone but a psychiatrist or mental health specialist. We really wanted to create a replicable model that could be used in low-income settings, and knowing that there's so few psychiatrists in particular, but mental health specialists in general in low-income settings. We were eager to find a model that could be applied to different types of settings. And we were able to overcome this challenge because we couldn't find mental health providers who were willing to work with MDR patients. And so we ended up having psychiatrists co-lead the group with, or nurses co-lead the groups. And in some cases, the nurses were able to facilitate the groups on their own. This is an early stage of task sharing that worked out, and so it has relevance to other settings. Talk about barriers. What are the barriers to TB and mental health treatment initiation? This is an ongoing preliminary results from an ongoing study, which was the main activity of the working group, the TB and mental health working group during the past year. And this is a survey of national TB program directors globally. And the data that I'm going to share is based on the first 20 interviews with national TB program directors. The interviews were 30 to 45 minute semi-structured interviews. Countries highlighted on the map are the ones, or the first, well, we've 24 so far, but I'm going to present the data on the first 20. These are the countries that have been included so far. If you don't have your country on that highlighted and you have to facilitate the national TB director in your country to participate in this, please reach out to us. I'd love to expand the representation. Reasons associated with this study. The first is, what are the perceived needs of global national TB programs with respect to mental and substance use disorders? So, what are the practices, protocols, and access to treatment? And what national TB programs to integrate TB and mental health services? So main barriers were identified as barriers to TB and mental health service integration. These include not capacity, which is endorsed by 70% of the first 20 interviews, not underfunding, a lack of awareness, or that mental health was not recognized as a problem, and these were endorsed by half of the interviewees. Individually. When it comes to capacity, there's a few challenges. The first, particularly in settings with youth specialists, the first is case detection. And this can be difficult for a number of reasons. Often symptoms are overlapping. This is particularly the case with depression, where anemia or loss of interest, changes in appetite, low energy, a lot of symptoms overlap with symptoms of TB, and so they can get missed and assumed that it's TB when in fact perhaps it's a comorbid mental disorder that can be treated. So, a lot of conceptions about what is situational distress versus clinical illness. On the other hand, a person who's very ill, acutely ill with, in particular, drug-resistant tuberculosis, it makes sense that a person would be in a lot of emotional distress as a normal reaction to that abnormal situation. However, there are times when that stress is to such a degree that it becomes a clinical disorder, and it's something that can be treated. Often there's also a misconception that of course they're depressed, they're poor, they're sick, and so the diagnosis is often overlooked. And really, even in settings, maybe it's very obvious that the person is having psychiatric issues, but a provider might not be to ask about it if there aren't many services available, not much that can be done. And one of the main tools to overcome this challenge is our before screening scales. This is the PHQ-9, the one that I mentioned earlier. Just an example, a 9-item scale that can be It can be administered in high-income settings, but in settings with low literacy levels, it can be administered by a community health worker or other person, lay person. Read the questions and complete the survey with the patient. For anxiety, the Generalized Anxiety Disorder 7-item scale is another example. There are similar examples of tools that are used for disorders, the audit, the CAGE, and there's tools for PTSD and other psychiatric illnesses, as well as disability. The HUDAS, the WHO disability scale, is an important tool to determine the degree of impairment. So sometimes it can be administered at the same time as the depression anxiety scales, for example, to determine how severe are the symptoms, but then also how disabling are they? What kind of disability is associated with the combination of TB and mental disorders? So there's been a lot of research over the past decade, which is with way too much to cover in this webinar, but we hope to talk about more in the future, about how to adapt and test evidence-based interventions in low-income settings. Generally, these models rely on task shifting or on specialists to deliver the care, and now a very strong evidence base for several interventions. According to this an article, it's part of the global mental health movement, MH-GAP from the World Health Organization. There are several randomized controlled trials that have demonstrated that collaborative care models can work in low-resource settings when community workers and nurses are trained to deliver evidence-based psychotherapeutic interventions. For example, interpersonal psychotherapy, cognitive behavioral therapy, behavior activation, and problem-solving therapy. Symptoms through care coordination with expert supervision. So the core interventions are the ones that have been recognized by MH-GAP, by the WHO, as evidence-based practices, and there have been trials and efforts underway to create more training materials so that these types of evidence-based interventions can be eliminated. And this is a great need in the area of TB, is looking at these types of interventions and adapting them to the context of TB treatment disorders. With enough resources and funding, it's important to note that each person not receiving adequate treatment can expose up to 10 people per year, sometimes with drug-resistant strains. And really, it comes down to the fact that it's too expensive not to treat. A historic meeting at the Shadows happened last year in April 2016. Hosted by the World Health Organization, the World Bank, and National Institute of Mental Health. And the purpose of the meeting was following the inclusion of mental health in the Sustainable Development Goals, was how to bring mental health into the development agenda. The World Bank made a statement that said that each dollar invested in mental health treatment for depression and anxiety returns about $4 in improved health and ability to work. And certainly this would be the case with tuberculosis. It's expensive to not treat than to treat correctly the first time around. Treatment success, in other words, saves me. And so this is going to involve a paradigm shift. There needs to be investment in mental health in order to reap the benefits and maximize the use of limited resources. And rely heavily on task sharing. So the last of the top three barriers was that the lack of awareness, or that mental health was not recognized as a problem. The question on the survey, this was one of the most surprising findings so far, is that the question is, if the necessary training on the above-mentioned interventions that I mentioned earlier, if they were available, the training were available in your country, what is the likelihood that it would be integrated into standard TB care at a national level. And 85% of respondents within the first 20 interviews responded either highly likely or somewhat likely. This high receptivity to integration is very encouraging and hopefully will help us to overcome this barrier to integration. Okay, I'm going to talk about how this fits into the NTB strategy. Excuse me. The World Health Organization recently released a post-2015 strategy to achieve the Sustainable Development Goal of ending the TB epidemic by 2030. This is based on 3 pillars. There is patient-centered TB care and prevention, bold use and supportive systems, and research and innovation. Pillars relates to mental health in ways treating health in the context of TB is strongly aligned with each of these pillars in ways that I'm going to describe now. Components of Pillar 1 have this early diagnosis, treatment and patient support, managing comorbidities, and prevention. And there's mental health for each of these. Early diagnosis, we know that treating mental disorders can reduce treatment delays and therefore lead to earlier diagnosis. Incorporate social, psychological, and/or material support are associated with better outcomes and can be considered a best practice being put forth by the World Health Organization. Care, which includes the treatment for comorbid mental disorders, can improve adherence and survival rates. We know this from other illnesses, but we also are learning more and more that this is the case with tuberculosis. And treating mental disorders can reduce the risk for developing active TB, so can play a role in improving prevention efforts. Key components of Pillar 2 include political commitment, social protection, community engagement, and youth care. And for the political commitment, as you saw in the survey of National TB Program Directors, there appears to be high receptivity to mental health integration. And so this commitment may actually be there and could be leveraged to address these issues. The World Health Organization endorses that social protection, which includes mental health, is a key element of the forward strategy to end the TB epidemic. It's no longer sufficient just to provide medications, but also to look at a patient in their own context, and a patient-centered model involves looking at poverty and addressing poverty through things like conditional cash transfers or financial assistance for secondary costs like transportation, et cetera, as well as looking at mental health and addressing these needs, along with community engagement and universal health care. And finally, intensified research and innovation. Science is a field that aims to take research out of laboratories, out of the controlled environment, and see how it can be applied in complex real-world situations. There's several kinds of implementation science research that is needed in this area to address mental health and help to end the TB epidemic. The first is to make these brief screening instruments available in more settings through translation and cultural adaptation. We need to look at cutoff scores, because some of the, when I was talking about depression, for example, there's a lot of overlapping symptoms. Maybe we need to use a higher cutoff for HQ9 when we're looking at a TB patient, for example. So we need to do more variation studies around that so that these tools can be broadly. We also need to test the effectiveness and cost-effectiveness of evidence-based mental health treatment interventions for improving TB outcomes, as well as explore the mechanisms of change and how change happen. What are the parts of the intervention that are contributing to the change that is observed, and at basic science level, we need more biomarkers research to better understand the interaction of TB and mental health at a physiological level. To wrap up, but I wanted to make a pitch before concluding that we would love for you to join the TB and mental health working group. If you're a union member, you can go to the union website, and these are some instructions that we'll send out in an email following this webinar. But please consider joining. If you're a union member, you can send email requests to me at this email address, and I will add you to the email list. By joining the group or the email list, we'll be able to keep posted on additional training opportunities, and I have lots of ideas that are sort of floating around about how can we really link providers around the world that are this work. How can we begin to answer questions? So there's a lot of activities that are on the horizon, and by joining the group, then you'll be able to stay abreast of these updates. The thing is that from an advocacy standpoint, it's important for us to show that the numbers through the union, that we have a lot of participation in the working group. This helps elevate the visibility of mental health at the union level. So if you're of the union are able to join through the site, we would greatly appreciate it. And that's all. So I'd like to just a few acknowledgments, thank the union, be hosting the webinar and other training activities following this activity. The National Institute of Mental Health, which is funding me, the medical school for hosting this webinar, Sociomedical for helping to prepare materials and setting up this interview, the university, which is my institution, as well as the World Health Organization. And really, a very big thanks to Jerome Galli, who with him, very difficult for this to happen. So thank you very much, Jerome. And I think I can pass the baton to Jerome, and we can start looking at some of your questions. Thank you.
Great, Annika. That was great, and an extremely useful scoping view of mental health. So we're right up to the hour. Some participants will need to leave. We will be contacting you afterwards with a link to the full recording. So if you have, that's okay. But we'll hang out for a few more minutes to take some questions that we've received. Please remember also that we'll be contacting everybody with a survey following today's session to help us improve in future, both in content and so for the technical aspects, which I know we're doing for some people. A few questions right now for Dr. Sweetland. Annika, one of the first questions we had was regarding psychosocial support groups that you've discussed. There's some question about concern on infection control. The question is, were psychosocial support groups only for culture negative patients? Address that, please. In mute.
Sorry about that. That's a good question, and that's going to be a challenge moving forward, thinking of how to do these types of interventions. In this case, these patients were in a 2-year treatment for multi-drug resistant TB, so wait a little bit longer was in the HDL. The criteria for participating was 2 negative cultures before participating. Now, when we think about doing interventions in regular drug-susceptible TB, which is only 6 months, the infection control is going to be something that we need to keep thinking about and try to figure out how to get around, because obviously we wouldn't want both the health workers who are running the groups to have a risk of exposure, but also know that patients can fit drug-resistant strains to one another, and we would not want to increase that risk. So definitely only non-infectious patients were to participate, and made a very deliberate effort to find meeting spaces that were well ventilated and as open as possible as an additional precaution.
Here's another question also about the groups. Could you talk a bit about how often the groups were held? Was it once a week, twice a week, or?
It started out when we got started for the first 6 months or so, maybe even longer. We started out, it was every week. The psychiatric were the level of stress was very high, and it was very clear to us that it needed to happen once a week. Later, when there was a bit more stability in the groups, because a proportion of the patients participating had less distress, we're able to reduce that to twice a month. But I think it went up and down over time depending on the needs.
I have one last question that I've received. Wrapping up here, if anyone has a question, you can please type it inside the chat window. This question is regarding impact evaluations for the groups, their intervention to our randomized controlled trial type sort of information. Do you have any information about that with regards to working in TB, but specifically, for example, in motivational interviewing or adaptations of other programs? This says that even this in the HIV world, but not in the TB world. Maybe address that.
Sure, that's a great question, and that's precisely what we hope happen in the next few years. Informally, I know of a few programs that are doing that, and so hopefully the evidence will be coming out in the next few years. And there was the treatment protocol that I mentioned that involves not in a clinical trial, but the health providers in that setting in Ethiopia have been trained to with GAP from the WHO methods, and so they have some access to training and able to look and see if people who access health services have improved outcomes. But this is a significant research gap. This is research that is needed, and there are a number of studies that are currently ongoing, and I look forward to the ones there so we can understand. The important thing I would say is that programs considering implementations and testing interventions is to the greatest extent possible to stick to some of these evidence-based models to have replicable findings. We've learned a great deal from working with HIV, for example, or working with other conditions, and we need from them and not start and learning from collaborative care work as well as cash shifting work is going to help us to move this forward. Again, as I mentioned at the beginning, the working group, the purpose is to find providers in the field that are confronting these issues and trying to address them. We can make these links. Maybe they have the capacity to treat patients, but not the capacity to measure outcomes. And so I hope that if anyone listening who fits that situation can reach out, and we can try to create fruitful collaborations where researchers can be paired with providers to help do rigorous evaluations so that we can create this evidence base.
Flowing in, we still have a few minutes. Back to the issue of group and whether patients were clear negative. There's a clarification. I think I had jumped to the conclusion she may have been around infection control, but there's a question about whether it's possible to do something similar for in the intensive phases, which is often the phase which is the most difficult and most taxing. Patients feel really bad, and they're often completely isolated. Do you address that issue?
Yeah, like I said, this is this evolving field. This is a open research gap, an area that we need to assess with implementation science and innovating in this area. I think technology may be able to play a role in the future, not immediately, perhaps in low-income settings, but smartphones and online interactions where there isn't a person-to-person connection over the phone, that there's a lot of promise for technology playing a role. Really is I wish the answer to that, because that's just going to be one of the challenges, especially in terms of rolling out these types of interventions at systems level. And so, if ideas, I would also be welcome. I'd welcome them. I wish I had the answer to that question, but it's a question that must be addressed.
There are a few more questions, and I realize that we're now running over, but I hope that we can continue this conversation in other spaces. But I can end by asking Annika, if you had to leave today with one thing that we could all do in our respective countries and programs, towards at least providing some mental health services or psychosocial support. Start around is a complicated issue. We know regarding resources, political will, and so forth. Lots of things happen in tiny steps. Just like it began and improved all those years ago with your early work. Is there one, and this is hard, but if you had to, if you were cornered, is there one thing that you would want participants today to kind of weigh as something that could happen in the very short term in things where there are no services to be able to move this agenda forward as we work towards more universal coverage and integration of health services with TB programs?
Actually, I can address that. There's two things. One, first of all, would be to join a working group and/or this email list, because we're going to be, dynamically trying to address these issues and create resources and train resources, everything that'll be free and as accessible as possible. Staying in the loop of this group would be the first thing. The second thing I would say would be to begin to do screening in your things, because these 9-item, 7-item mini can help you to figure out to get an idea of what the scope of the problem is. Is this a huge challenge in your setting? And does that mean that this needs to be addressed? Also, just on an observational or operational sense, you start looking at, how are the outcomes associated? So what if ones that came out positive on this, are they the ones that are less likely to adhere to treatment? And starting to see those patterns and associations can help not only have a better understanding of what's needed, but also begin to garner the political will and support that we needed, the data that would be needed to drive investments in this area.
Well, I apologize if we weren't able to address everybody's questions today. However, as you saw by now, the session has been recorded. We will be contacting all participants or all registrants for today's session with a brief survey to help us improve in the future and deliver the content in the best way possible. You can reply to us with your questions. I also want to mention that the Union World Conference on Lung Health is sending abstracts by the mental health until the 10th. If you're not part of the union, we encourage you to join. It is the preeminent space for TB research, but also increasingly comorbidities like mental health. Again, we also invite you to join the mental health working group. We will send you information on that. I wonder, Pep, did you have any closing words before we leave today?
I just wanted to mention that we would like to make this training available in other languages. I'm able to do so in Spanish and Portuguese, and so we hope to do that relatively soon. We have the goal of trying to make this material more accessible, and so please be patient, and any ideas of how to help achieve that goal would be much appreciated.
Great. With that, we thank everybody for their attendance today. Thank you, Dr. Sweetland. This was an excellent presentation, and we hope to see you all in a forthcoming webinar, and then later on in the year at the Union Conference at the Mental Health Working Group for sure. Thank you. Good morning, good afternoon, good evening, wherever you are, and we will be in touch. Take care, everybody. Goodbye.